Hello. Uh, I want to know if the voice is clear. Please, if you can tell me in the comments if the voice is clear or not, or if there is any problem with the live video. I want to welcome all of you today, and I wish that all of you are staying safe and in a good health. Uh, uh, sure, during these days we are not able to work as in the past. We are not able to have our daily activities like before, but although we are staying homes, but we can stay growing, we can stay study, we can keep learning through the online courses, online webinars, and I hope that all of you are safe and are in a good state. Uh, Today, I want to discuss with you a very important topic in endodontics, which is the access cavity preparation, because for sure, access cavity is considered the most important topic in endodontics because a good access cavity will allow you to have a good cleaning and shaping, good canal disinfection in the future, and of course good duration. So focusing on doing a good access cavity preparation will make the life easier during the subsequent steps of your root canal treatment. Uh, so we have some objectives for the access cavity preparation. We will talk about the general objectives, then we will discuss every point in details in the future slides. When we are talking about the access cavity preparation in endodontics, we have general objectives like we want to penetrate the occlusal surface and to find the pulp chamber. Second, we want to unroof or make what's known by de-roofing for the dentin that covers the pulp chamber, and of course to find or locate all the canal orifices and have the direct access to the orifices. Then we want to have a straight line access from the occlusal surface till the apical foramen or to the initial or the first curvature of the canal. This is to decrease the stresses on our instruments. Then we want to have a uniform contact of the file with the access cavity walls, which means that we will need smooth walls of our access cavity. This is decreases the stresses on the instrument, so we can have the complete authority over the enlarging instrument and decrease the errors in the apical part during shaping. Then Of course, in any type of access cavity, we want to conserve the tooth structure in order to be able to restore these tooth and to have accepted or a good longevity of these tooth. We have a general guidelines for access cavity. Of course, visualization is a very important during access cavity preparation and in dentistry in general. Magnification and illumination. Today we have a lot of facilities that will allow us to see more in order to be able to see a lot of details that we were not able to see in the past, like magnification loops and microscopes. Uh, Today, uh, this allows us to have a good visualization, and also with the advanced types of light, we are able to see a lot of details during our treatment. So, of course, the more you can see, the more you can do. And also, a good reading for the preoperative X-ray is very important because from the preoperative X-ray, you can see the platform of your access cavity preparation that you will do in the future. If you have a small platform or a large platform of the pulp chamber, you get the pointer. If you have a small platform like here or a large platform, you can decide which type of access cavity you will do, as we will discuss in the future slides. You will be able to see the restorative material. If you have restorative material in the tooth, you will be able to see the number of roots and the narrowness of the root canals. If they are narrow, the number of roots and root canals. So you can modify your access according to these points or according to the findings that you will see in the preoperative X-ray. Now we will talk about the steps of the access cavity preparation in general, and then we will discuss each step in a separate slide. For doing the access cavity preparation in a successful way, the very first step, we should make a complete removal of caries, because caries means bacteria. So if we are going to open our access cavity and going directly into the pulp chamber without complete removal of caries, so we have a bacteria remaining in our access cavity or near our access cavity. These bacteria will enter inside the pulp system during shaping, so this is going to cause some sort of contamination for the pulp system and subsequent failure. So a complete removal of caries is one of the most important, very first steps that we should consider before opening our access cavity. Second step is the removal of restorations. Uh, if you are doing root canal treatment for a tooth which has a coronal restoration before, so you should remove all the restoration, even if this restoration looks nice from the outside, because this restoration may hide a recurrent caries underneath or a crack under this restoration. So if you are not sure, or even if the restoration appears pretty nice from the outside, so you have to remove it also, because even if the restoration appears nice from the outside, you are not sure if it hides a crack or a recurrent caries underneath. Then we start to draw with our burr or our stone the initial external outline form of the access cavity, and we are gonna discuss the external outline form for each tooth in a separate slide in the future slides. Uh, then we do a dropping into the pulp chamber till we have a color change, as we will say. And all these steps from the removal of caries till dropping into the pulp chamber, we do these steps with a diamond stone or a round burr. Then after we drop into the pulp chamber, we will start to do what's known by deroofing or removal of the pulp chamber floor, the pulp chamber roof, I'm sorry. The dentin which is covering the pulp chamber is called the roof of the pulp chamber. We need to remove this roof of dentin in order to have accessibility into the pulp chamber and in order to locate our canals. So we do deroofing or removal of the pulp chamber roof. This step is done with a different type of burr called the Endo-Z burr. This Endo-Z burr is a safe-ended burr. It's a non-cutting end. It cuts only from the sides, so it decreases the risk of floor injury or floor perforation during the deroofing procedure or during the removal of the pulp chamber roof. After doing your deroofing and you have accessibility into the pulp chamber, you need to have these walls of the pulp chamber to be smooth, because as we said in the objectives, we want to have a smooth contact between our enlarging instruments in the future and the walls or the access cavity. So we'll start to check these walls if they have any irregularities or any sharp area or any catchy area. There may be a small part of the pulp chamber roof which is not removed. This will cause an irregularities in these walls. So with a curved probe, we start to check these walls for any irregularities. And, and if any area here have an irregularity or have a catchy area, we'll start to make what's called the refining of our access cavity preparation or refining of the walls. This is best done with an ultrasonic tip. An ultrasonic tip preferred to be a non-cutting one also, like the Endo-Z burr, but it's more gentle than any burr in general, so it can make this refining in a good way, and it decreases the possibility of floor injury or decreases the possibility of perforation. Here we want to discuss a very important procedure during or after the access cavity opening, which is the pre-endodontic buildup. After opening the access cavity and after complete removal of caries, of course, and of course you remove any restoration that you have, you may end up with something like this. The missing walls of this tooth distal wall is completely missed. A part of the buccal and a part of the lingual walls are missed. So proceeding with root canal treatment without building your walls, without building these walls will cause problems in the root canal treatment in the future, as you will say. So we need to do what's known by a pre-endodontic buildup. You will need to rebuild those walls. You need to restore your tooth and have your tooth with a forward walls once again. So why we have to do this pre-endodontic buildup? For many reasons. The first reason is for isolation. Uh, Of course, if you have a tooth like this with uh, three walls are missing nearly, or distal wall, part of the buccal and part of the lingual wall are missing, so the isolation will not be the best isolation. that you can have. The clamp stability will be affected. The rubber dam sheet inversion will not be the best also. You can have leakage of the irrigant or for any material that you will use in the subsequent steps of root canal treatment. So having your tooth again with four walls will give you a better isolation. And also for irrigation. First, for irrigation, in order to avoid leakage of the irrigant solution, and the most important is that during our root canal treatment, we need to have a basin of irrigation inside the pulp chamber. We need our irrigant to remain inside the pulp chamber during our shaping procedure. So with something like this, with these missing walls, the irrigant and or the sodium hypochlorite will slip away or will leak away from our access cavity. So we will have leakage. We can't keep our irrigant inside the pulp chamber, so for irrigation it's important. And also for reference point determination. For sure, we have missing walls, so we will have missing cusps. And for reference point determination, we need to have a fixed and irreproducible reference point. So we need to build the missing walls in order to have a reproducible reference point. And also for apex locator accuracy. If you are measuring your working length with an apex locator, with these missing walls and with a lot of leakage, of course, the reading of the apex locator will not be the best. You may have errors with the apex locator reading, so you have to build these missing walls in order to have a good isolation, good irrigation, and to be able also to activate your irrigation, and for reference point determination, and for apex locator accuracy. So how we can do our periodontic buildup? We have two ways. We can remove caries only, then you can use any restorative material like resin modified glass ionomer or composite restoration to build these missing walls. Then you proceed with opening your access cavity. This is done especially when the access is not already open, when you have caries only, which is reaching the bulb, but you have no actual exposure. But in cases if you have already an actual exposure in the tooth, so you can open your access cavity, then you do a pulpotomy or removal of the pulp tissue from the pulp chamber. Then to avoid having the restorative material to go inside the pulp chamber, you block your pulp chamber with a cotton pellet, or you better do it with Teflon. Then doing your buildup and remove the Teflon, and you will have your access cavity open. This is 4 photos for the sequence. Here we have the access cavity opened. We blocked the access cavity with a piece of Teflon tape, then re-walling or rebuilding of the missing walls. Then by removal of the piece of Teflon, we have our access cavity open. Now we will talk about some rules about the access cavity. Actually, these rules will make us safe, will make us understand more the anatomy of pulp chamber, the positions of the canals, and will make us able to do our access cavity in a more predictable way. We have some laws like laws for pulp chamber anatomy, laws of symmetry, laws of color change, and we have 3 laws for orifice location. Let's start by the 2 laws of pulp chamber anatomy. The floor of the pulp chamber is always located in the center of the tooth, and this is a very important piece of information, that in any tooth, the pulp chamber or the pulp cavity is always located at the middle of the tooth. It's not located mesially or distally, or it's not shifted to any direction. It's in the middle of the tooth. I know that you will start to think about the upper molars, that we do our axis cavity from the mesial side. So you will think that if the pulp tissue is inside the tooth in the middle part, or inside or shifted to the mesial side. No, it's not shifted to the mesial side, it's in the middle of the tooth. We only do our access from the mesial side to have an accessibility for canal orifices, but in fact the pulp tissue or the pulp chamber is located at the middle of the tooth for all of it. And the floor of the pulp chamber is located at the level of the CEJ, of the cement-to-enamel junction. The second law for pulp chamber anatomy is that the distance from the external surface of the clinical crown to the wall of the pulp chamber is the same throughout the circumference of the tooth at the level of the cement-to-enamel junction, which means that the floor of the pulp chamber, or the boundaries of the pulp chamber, will not go beyond the uh, the periphery of the cement-to-enamel junction. If you are looking from an occlusal direction, so you will have two levels: the level of the crown from uh, from the middle third or the occlusal third, and there is a smaller level at the level of the cement-to-enamel junction. The level of the bulk chamber will not go beyond the level of the cement-to-enamel junction. This causes the cement-to-enamel junction to be the most consistent and repeatable landmark for locating the position of the bulk chamber. The bulk chamber location is located within the circumference of the cement-to-enamel junction and will never go beyond it. This is for the bulk chamber anatomy. We have two laws which is known by laws of symmetry. Remember that these laws are not applied for maxillary molars. This is for mandibular molars and upper premolars mainly. Except for maxillary molars, canal orifices are located at the same distance from a line drawn in a mesiodistal direction, which means if we draw a line in the middle of the tooth in a mesiodistal direction, so the canal orifices are located at the same distance from this line. And also the canal orifices are lying on a line that is perpendicular to the first line. These are the two laws of symmetry. This will help us during during opening our access cavity for lower molars, especially because if you are opening an access cavity and you start to draw this line in your mind, you draw this imaginary line. If you find that this line is not passing in the middle and the canals are not distributed in equal spaces from this line, so you may have to extend your axis in order to accommodate all the canals and in order to have no missed anatomy. So drawing this imaginary line in your mind during working will help you a lot. The next law is the law of color change. In most of cases, the color of the bulk chamber floor is darker than the walls. The bulk chamber floor is a little bit grayish, having a gray color or a dark brown color in some cases, and this is different from the color of the yellow dentin. So when you drop into the bulk chamber, as we said in the steps, when you drop with your burr, with your round diamond burr or carbide burr, so you start to see this dark color. So you uh, start to be sure that you are in the right way. You are dropping into the bulk chamber when you see this color change. We have next three laws for orifice location. The first law says that the orifices are always at the junction between the wall and the floor. If you see this axis, this is the floor and this is the wall. The orifices are located at the junction between the floor and the wall. This is for all the orifices. And the second law for orifice location is that orifice is always at the angle of the floor-wall junction. So it's at the junction between the floor and wall, and always it is in the angle of the axis, or at the angle of the floor-wall junction. The third law for orifice location is that we have something in the floor of the bulb chamber which is called the root developmental lines, or we call this the Denton map. These root developmental lines will guide us a lot during the axis cavity preparation and during the orifice location, because every line, every root developmental line, it always has a canal in the beginning of this line and another canal at the end of this line. So if you find a line here, for example, so for sure there is a canal at the end of this line. So we are calling it Denton map, as it guides us as a map during our axis cavity preparation. Now we'll discuss the outline form for each tooth, the axis outline form for each tooth. For upper anterior teeth, the outline is at the middle of the middle third for the upper central and lateral incisors, and it's nearly triangular in shape. For the upper canine, it's nearly oval and also in the middle of the middle third. And for the upper anterior teeth, we have two pieces of information which are important that we should talk about. In the upper anterior teeth, we have two things. We have what's called the lingual shoulder and what's called the labial bulb hole. The lingual shoulder is a piece of dentin opposite to the cingulum from the inside. So during our axis cavity prep for upper anterior teeth, we should consider removal of this lingual shoulder in order to have a straight line access to our canal and in order to decrease the stresses on our instruments in the subsequent steps. And here we have something called the labial bulb hole. The labial bulb hole is a piece of bulb tissue which is located more labial. So failure to extend our axis cavity to remove this bulb hole, this will cause the not removing this piece of bulb tissue. This will cause a bulb tissue left inside our axis cavity. This can cause recontamination of our bulb tissue, of our bulb system, and can cause a discoloration for the tooth in the future and can lead to subsequent failure. So removal of the lingual shoulder and removal of the labial bulb hole is a very important points to consider during axis cavity preparation for the upper anterior teeth. For lower anterior teeth, for lower central and lateral incisors, our axis cavity outline is nearly oval, and also for the lower canine, it's nearly oval, and we do it usually from the middle of the middle third. For maxillary premolars, usually we have two canals. Some maxillary premolars have three canals, and we will discuss this point later on in the presentation. But in most of cases, we have two canals, and the axis outline is nearly oval, and here we can apply the rule or the law of symmetry. So if we have an imaginary line which extends from the mesial to distal side. We will have our canal orifices lie on a line that's perpendicular to the first line and on an equal spaces from this line. For the mandibular premolars, generally the access cavity is in the middle of the occlusal surface, and it's nearly circular, maybe oval, but we have to mention that the mandibular premolars are having a lot of variations. You may have a mandibular premolar with 2 canals, you may have a mandibular premolars with 3 canals. So, as we said in the beginning, a good reading for the preoperative X-ray can give us a lot of information about the number of roots and number of canals. So, by knowing that we have 2 canals or 2 roots, we will be able to modify our access cavity. Like in this case, we have a fast break phenomena in the X-ray. So we consider that we have splitting in the canals, and we start to think that we may have to extend our access cavity in order to accommodate this splitting and to order to have no missed anatomy. For molars, we have to mention that the outline of the access cavity is following the same outline of the pulp chamber, and actually this is applied for all teeth. For the upper molars, the access cavity is nearly triangular. For lower molars, it's nearly trapezoidal, as we have 2 mesial canals and one distal canal. If we have 2 distal canal, it can be rectangular, so it follows the shape of the pulp chamber. For the maxillary molars, we have now we can say we have 4 canals in the maxillary molars, as the second mesiobuccal canal, it's not an accessory canal or an extra canal anymore, and we will talk about this also in details in the future slides. The first mesiobuccal canal and distobuccal canal, palatal canal, and a second mesiobuccal canal. For the canal locations, the first mesiobuccal canal is located nearly under the tip of the mesiobuccal cusp. The distobuccal canal is located distal to the groove that separates between the mesiobuccal and the distobuccal cusp. Here is the groove in yellow color. The distobuccal canal is located nearly distal to this groove. The palatal canal is located at the nearly under the tip of the mesiopalatal cusp, and you can say also it lies at the junction between the mesiopalatal cusp and the oblique ridge. Here is the oblique ridge in green, and the palatal canal in most of cases lies at the junction between the mesiopalatal and the oblique ridge. The second mesiobuccal canal is located nearly some a little bit mesial and a little bit palatal to the first mesiobuccal canal. So our access cavity is nearly triangular, like you see. And again, we say that the pulp tissue or the pulp chamber is not shifted to the mesial side. It's in the middle of the tooth, but our access cavity is lying in the mesial side because the canal orifices are located or are shifted toward this mesial, but actually the pulp chamber itself is at the middle of the tooth. Here is another clinical photo to demonstrate the position of the second mesiobuccal canal, or to say that where can we search for the second mesiobuccal canal. Imagine that you are searching for the second mesobuccal canal, and you want to know how you start searching or where to start searching for it. So uh, a nice map that you can draw in your mind, that you can have an imaginary line that is passing from the first mesobuccal canal to the palatal canal, then draw another imaginary line from the distobuccal canal and going to intersect perpendicular with the first line. At this point of intersection that you will start to search for the second mesobuccal canal in this area. So it's a nice idea to draw in your mind where is the area in which you will start to search for the second mesobuccal canal. And we will get back to the issue of the MP2 canal again in the future slides. For the mandibular molars, we have generally three canals: mesobuccal canal, mesolingual canal, and a palatal canal, and a distal canal. These three canals, the mesobuccal canal lies nearly under the under the mesobuccal cuspid. The mesolingual canal lies nearly at the base of the mesolingual cusp, and the distal canal is located nearly distal to the central fossa of the tooth. And here we can apply the law of symmetry. If you draw an imaginary line from the mesial to the distal, so the canals are located nearly on equal distances from this line, and also they are perpendicular to this line. Now we'll start talking about extra canals. So we are saying that lower molars are having three canals, and upper molars 3 or 4 canals. So we are having some extra canals in the teeth. Now we'll start talking about, if you have an extra canal, how you can start searching for it and how can you find it. First, we'll start to talk about the MP2 canal, the second mesobuccal canal. As I said, the second mesobuccal canal is not considered an extra canal anymore, because by evidence, according to this study, a worldwide analysis for the maxillary first molar second mesobuccal prevalence, you will see that we have a very high prevalence. In Greece, 53%, in Italy, 74%, as you can see in the results. In Spain, 86%, in Egypt, 74%. So in Australia, 50%, and in Syria, it's a very high prevalence, about 95%. So as you can see, it's not considered an extra canal or an accessory canal. It's considered that it's always there, so we have to search for it in every tooth. But a lot of clinicians can report that the second mesobuccal canal is hard to negotiate. So is it really hard to negotiate? I'll tell you something. A case like this with the second mesobuccal canal, after preparation of the 3 canals, mesobuccal, distobuccal, and palatal, you start to search here and you can find a catch with your small file. A small file like number 10 or number 15, you will start to have a catch here, like in this photo. After feeling this catch, you start to force and to introduce the file in order to advance more inside the second mesobuccal canal, and you end up by file separation inside this canal. And you get surprised that every time you start to negotiate this canal, the file gets separated. So what is the right way in order to negotiate this canal without file separation. And of course, there is something special about the second mesiobuccal canal. Is that this canal is always having a piece of dentin, a piece of sound dentin over the orifice of the second mesiobuccal canal. So before trying to insert a file inside the canal, so you have to manage to remove this piece of dentin, or as they call it, a dentin shelf. So we start first by removing this piece of dentin with an ultrasonic tip, or with a maybe rose head burr on a slow speed handpiece. Please don't use a high speed. A high speed is a very risky in this situation. Ultrasonic is the best. And by removing this piece of dentin, you will be able to negotiate the canal with files in a safe way without having file separation. This is after canal negotiation with the orifice opener file, and as you see, it was very near to the first mesiobuccal one, and they start to open on each other one canal. This may happen in some cases, but the message from here is always try to manage to remove this piece of dentin which is over the canal orifices, and this is how to negotiate the canal safely without having your file separated. So always remember that the second mesiobuccal canal is like a room. You want to enter inside the room, but this room has a door. So you have to open the door first in order to enter inside the room in a safe way. The door is this piece of dentin that you have to remove in order to open the door and negotiate in an easy and in a safe way without having your instrument separated. This is the MP2 canal. The second extra canal that we will talk about is the second distal canal in lower molars. In many of lower molars, we can have the second distal canal, so we are having our molar with 4 canals. But of course, I will not talk about this case because it's very easy. I will talk about a little bit harder case. This case, this photo is after opening the access cavity. Here, as you can see, we have mesiobuccal, mesiolingual, and a distal canal which is appearing to be a little bit oval, or appears as you can see a line, not an orifice which is not circular. It's not circular, it's a line. When I see this line, I start to think that this line may be not a canal, and this was right. A photo under magnification, this line was an isthmus, not a canal. Let's have it a little bit bigger. This was a line, an isthmus, it's not a canal. An isthmus or a line, this means that we have canal orifice at the end of the line from here, and another canal at the other end of the line. And here what I did is negotiation with manual files from the end of the line and from the other end of the line. I started to feel that we have two different directions, which means that we have two different canals, two different orifices. And this is the photo after negotiation with orifice opener in all the canals, and 2 orifices for the distal system are obvious here, and here is after the negotiation with manual files, we have 2 orifices. So when you are suspicious that you have no canal orifices which is circular, you have an oval appearance like in here, so you should suspect that this is not a canal. This is an isthmus which has two canals, one at the beginning and one at the end. This is for the second distal canal in lower molars, middle mesial canal. This is the same previous case with two distal canals. It has a middle mesial canal. The middle mesial canal is the canal which is located between the mesiobuccal and the mesiolingual canals in lower molars. And according to literature, this study was discussing the incidence of middle mesial canal based on the distance between the mesial orifice in mandibular molars. This study results in that the incidence of the middle mesial canal is about 14%, which is not a low incidence. So if you see, as in this case, that we have a long or a large isthmus between the two canals, so you can start to think that we may have an extra canal here in between. And to be frank, you should clean this isthmus in every case. And the key to find this canal is to clean this isthmus. If you clean this isthmus well with ultrasonics mainly, it's the best tool here to do this cleaning. You will start to have a catch here with your micro opener or your files. So here we use an ultrasonic tip in order to clean this isthmus, and after cleaning of isthmus we start to have a catch here between the two canals, so we made sure that we have a third canal here. And this is a photo after the preparation of the canal. So having a large isthmus will give you a nice indication that you may have an extra canal here in between. The lingual canal in lower anterior teeth. This canal is missed in a lot of cases, and it can contribute to failure because in many cases the lower anterior teeth may have two canals. One is labial and one is lingual. According to evidence, the second lingual canal in lower anterior teeth has a prevalence of about 32%. 32 is the number of teeth. It's about 15.5% in the lower central incisors and about 21% in the lower lateral incisors. So also it's not a small percentage. So we have to search for it, and we have to suspect that every lower anterior teeth that we treat is having two canals. So to detect this canal, we start to open our access, as we said, in the middle of the middle third about the cingulum. Here is an incisal view. After doing your access cavity in this conventional way, you will have your file sliding into the labial canal, and you can miss the lingual canal. So how can you detect this canal? You will not make more deroofing toward the lingual side. You will not extend your cavity more toward the lingual side. Why? Because the lingual side contains the cingulum, and this cingulum forms the most bulky dentin part of the tooth. So if we start to make more deroofing towards the lingual part or towards the cingulum, we will destroy this area, and we will affect the fracture resistance of our tooth in a dramatic way. So in order to find this lingual canal without compromising the fracture resistance of the tooth, we have to make a roof, but in the opposite direction. We will make a groove in the labial side. With our burr or stone, we will start to make a groove in the labial side. As you see here from the incisal view, we made a groove. This groove will make some cutting of sound tooth structure from the labial side or the incisal side. We make a cutting in a sound tooth structure, but it's better than cutting in the cingulum area, because cutting in the cingulum area will cause a lot of damage and a lot of affection for the fracture resistance of the tooth. So a little bit cutting in the incisal area will not affect the fracture resistance of the tooth as when it's done in the cingulum area. And by having this groove, we can insert the file easily to be introduced inside the lingual canal. Here, as you can see, we have two files. One file which is located more labial inside the groove. This file is sliding into the lingual canal, and the file which is located more lingual, this file is going into the labial canal. So this is how you can locate the lingual canal in the lower anterior teeth. Molarized premolars. You may have a premolar, especially upper premolar, with 3 canals. So, of course, the access cavity design will not be the same as if you have a premolar with 2 canals. You will have to modify your access. You will have to make some extension in order to not to miss this canal, this extra canal. So you start to suspect, or you start to know that you have an extra buccal canal in the upper premolars when you start to see that the buccal canal, the first buccal canal that you find, is not centralized. That's called the buccal canal centralization. If the first buccal canal you find is not centralized in the middle of the axis, so you start to think that you may have the second canal in the buccal side. So that's by which in this case, if you draw a line from the buccal to the palatal side, and without finding this canal, this line will not pass inside the middle of your access cavity. So if you start to draw this line imaginary in your mind, you will not find it centralized. So you start to think that you may have to extend. You may have another canal in the buccal side. So the best tool in order to make this extension, or as we see Travincore extension, for to find the second buccal canal, is to use an ultrasonic tip in order to find the second canal. And after finding it, if you draw the same line in the middle of your axis from the buccal to the palatal side, you will have it centralized in the middle of your axis, and the two buccal canals are lying on the same distance from this line, and it will pass in the middle of your palatal canal. So next point is the calcified pulp chamber. In some cases, especially if you have an old age patient, you may open your access to find something like this. There is no color change as usual. The canal orifices are not obvious, as you see. This case is having 4 canals for this lower second molar. Here you may need some extra tools in order to locate your canals. Here I used a manual file, but you may need extra tools. You may need an ultrasonic tip, as we will say. You may need a micro opener in order to start searching for your canals. So this case was managed with ultrasonic tip, and please, in these cases, don't use the high-speed contra-angle handpiece. Don't use the usual cutting stones or diamonds that you were using during the access cavity preparation, because you will have a high risk of perforation in a case like this. In a case like this, in order to manage and in order to remove this calcification from around the orifices and from the pulp chamber flow, you may need the ultrasonic tip, as we did here. You may need the micro openers in order to explore the sides of your canals. And in order to remove this calcification, here we used the ultrasonic tip, and then we inserted the orifice opener file after making sure of the canal orifice's location. And here is the photo after we remove this calcification with ultrasonic and after negotiation with the orifice opener file. So the message from here is not to use the high-speed contra-angle handpiece. You may use the micro openers, you may use the ultrasonic. All of this is good. The orifice opener file, after you are sure of the canal orifice's location, will give you a nice result. After talking about the extra canals, we talked about the MB2, the second distal canal in lower molars, the middle mesial canal, the lingual canal in the lower anterior, and dealing with the calcified pulp chamber. Here we will discuss the different designs of our access cavity. We have a lot of designs. Some of them are modified in the last 5 or 6 years. Some of them are modern designs other than the conventional design. We have the conventional design, which will the it's the first one, and it is the one we were talking about during the last slides. All our points were regarding the conventional access cavity, but there are some other modern and or a more conservative access cavity, like the conservative axis, carriage-driven axis, truss axis, and the incisor axis. We will discuss each of these in a separate slide. The conventional access cavity, as we said, we make a complete removal of the roof of the pulp chamber, complete deroofing. This aims to obtain a straight line access from the occlusal surface into the apical foramen or the initial curvature of the canal. And of course, this decreases the stresses over the enlarging instruments. And this will increase the biomechanical preparation efficiency and will decrease the procedural errors. All these points are good, that we can decrease the stresses on the instruments and on the files, and the efficiency of our root canal preparation will be increased. But also we have some drawbacks for these flared walls and for the complete removal of the pulp chamber roof, that we make more damaging to the surrounding pericervical dentin. The pericervical dentin is the dentin which is in the cervical area. This this piece of dentin around the cervical area of the tooth is very important to be conserved, because it will contribute more to the increasing of the fracture resistance of the tooth in the future. So it's least conservative for the pericervical dentin, and also less conservation for tooth structure. This causes more weakening of the tooth structure and can decrease the longevity of the tooth structure. Although the subsequent steps of the root canal treatment and the biomechanical preparation can be increased in efficiency, but also that's not so conservative for the tooth structure. So, according to this study, which evaluates the remaining dentin thickness and the fracture resistance of the conventional and conservative access cavity, the result of this study was that the remaining dentin thickness was less in conventional group than conservative group, and the pericervical dentin was preserved more in the conservative group, and the dentin conservation afforded to an increased resistance to fracture. As we said, the more dentin we conserve, the more fracture resistance we will have in the future for our tooth, so the more longevity for our tooth. So from here, the concept of the conservative access cavity started to appear, in which we need to conserve more tooth structure. We want to conserve more of the pericervical dentin in order to increase the fractural resistance of our tooth. So this is the concept of the conservative access cavity, but it's more conservative, but also it has a drawback of having more limited access. Our access will be more conservative, but also it will be more small. Having a more smaller access may cause procedural errors during the subsequent steps of the root canal treatment, during shaping, root canal system disinfection and irrigation, and during obturation. Having a constricted access or a limited access can have some drawbacks. So we should talk about the requirements of the conservative access cavity. First, magnification and illumination. Magnification is a very important during performing the conservative access cavity, and it's better not to think about doing a conservative access cavity without having a good source of magnification and illumination, because for sure having a more narrow and a more limited access will make you not able to see all the details, all the root canal orifices. Your vision will be more limited. The amount of light entering inside the access cavity will be more limited. So in order to see what you are doing, you will have to have a good source of magnification and illumination. Second, the requirement is having an advanced imaging technique like the CBCT. Also for the conservative access cavity, as it is more narrow and more constricted, so we may have a risk of missed canals or missed anatomy. So having a preoperative CBCT prior to starting in the treatment will make us sure of the number of our canals, the number of the roots that we have, so we will not have a risk of missed canal or missed anatomy. Also, using the new file systems with the new metallurgic properties, the highly flexible files like the heat-treated file or CM wire files also will be good during performing this type of access cavity, because this access cavity is more limited, so we will have more stresses on our instruments. So using these types of heat-treated files and flexible files will be able these files are able to be a little bit twisted, or you can apply some stresses on these files without getting separated inside the canal. And also you need to have some tools for irrigation delivery and irrigation activation to be sure that sufficient cleaning is done for the apical third. And because of the same reason, as you have a limited access, So you can't be sure that the irrigation is delivered to the apical third, and you have a good cleaning and a good dissolution of the all the organic and inorganic remnants during the root canal treatment. So you should have irrigation delivery tools which may be more advanced than the conventional needles or side vented needles. You may have to have flexible tips for irrigation and special instruments for irrigation activation in order to be sure that you have done a sufficient cleaning in this type of limited access. Conservative access cavity. This concept is modified by Dr. David Clark and John Cademy. And you can revise this paper. It's very good about talking about the minimally invasive endodontics and the conservative endodontic access cavity. The concept of this access cavity is developed from the idea that we want to conserve more dentin, we want to minimize the tooth structure removal. This will, of course, increases the mechanical stability of the tooth for the long-term survival and function. Regarding the steps of this type of conservative access cavity, the point of entry is from the central fossa of the occlusal surface, and we do the extension which is necessary only for detection of canal orifices. We extend our cavity till we detect the orifices of the canals. There is no flaring of the walls. There is no unnecessary extension. There's no straight line access as in the conventional one. There is only accessibility for the canal orifices. This is for some conservation for the pericervical dentin, and of course for conservation of some of the pulp chamber roof. The second type of the conservative access cavity is the caries-driven access cavity. In this type of access, we reach or we fall inside the bulb chamber from the side of caries. The entrance into the bulb chamber is achieved from the same direction of caries invasion. We remove the caries completely, as you see in this case. We have a distal caries, and we remove the caries completely, and instead of going again from the occlusal surface and doing our oval access cavity in the conventional way, we continue from the same side of the caries and we make our access cavity and canal preparation. This makes us able to conserve some tooth structure from the mesial side, and as you see here, we have a part of the roof which is preserved, which is marked in red. This is a part of the roof which is preserved, but also we should be sure that we will be able to clean this area. We should have a source of irrigation activation or an instrument for irrigation activation like sonic or ultrasonic activation in order to be sure that this area will have sufficient cleaning. The third type is the truss access cavity, or we call it an orifice directed access cavity. This type of access cavity, the purpose of this type is to conserve the dentin bridge between the buccal and the lingual wall. If we have caries in this tooth and it's indicated for root canal treatment, this type of access cavity is indicated mainly for the lower molars. If we have caries, but if the middle part of the tooth is sound and we have sound dentin in this area, so we can make two cavities only, one for to access the mesial system and the other cavity is to access the distal system, and we can leave this dentin bridge or this truss between the two cavities. The purpose of this design is to conserve the dentin between the two cavities, or keeping a dentin bridge, as we said, between the buccal and the lingual wall. This type of access will maintain a connection between the buccal wall and the lingual wall, and this decreases what's known by cuspal deflection. Cuspal deflection means that if the two buccal and lingual walls are completely separated, if we remove this bridge or this piece of dentin, we will end up by having the buccal and lingual walls separated. And by separation of these two walls, we will increase the probability of the cuspal deflection, and this may end up with a vertical root fracture. So the conservation of this piece of dentin will keep the buccal and lingual walls connected to decrease the probability of the cuspal deflection and subsequent vertical root fracture. And here is a study to study the effect of truss axis and the artificial truss restoration on the fracture resistance of the endodontically treated teeth. The result of this study says that the truss axis cavity preparation improved the fracture resistance of the endodontically treated teeth with MOD cavities. As we said, that's because we remain or we conserved the connection between the buccal and lingual walls. So the amount of cuspal deflection decreased and the probability of vertical root fracture decreased. The next type of access cavity, of conservative access cavity, is the incisal access. In cases of lower anterior teeth, and if we have the area of the cingulum and the lingual side, if we have this area not curious, this area is sound, so we can do our access from the incisal part, and we can still have a straight line access to our canals. This is for conservation of the lingual surface and the cingulum area, and we can have also a straight line access. As you can see from this x-ray, if we do our access cavity from the incisal part, we can still have a straight line access, and we conserved all this area of the lingual side and the area of the cingulum in order not to weaken the structure, and in order to have a subsequent more resistance to the fracture in the future. For conservative or contracted access in general, we have some important considerations. These considerations were mentioned in this paper about some sorts of conventional and modern access cavity preparation techniques. As we said, that the contracted access cavity having some advantages, that we can conserve more tooth structure, we can conserve some very cervical dentin, but also having a more contracted access can cause some procedural errors, can have some disadvantages during our treatment, during the subsequent steps of the root canal treatment, during instrumentation, during irrigation. So it can't be done in every case. So case and canal selection is very important. We can say that the conservative or contracted access cavity can't be done in every case. It's case dependent. You can't do it every time. You can't do a truss access cavity for every lower molar. You can't do a conservative access cavity for every case. You should have select your cases, and case selection is based on a multifactorial issues like the condition of the bulb, vital is or necrotic, the level of difficulty, presence of calcifications, curvatures, and accessibility, Of course, if you have calcifications or curvatures, so you may have to extend or to make a more extension on your axis cavity in order not to do subsequent errors. And the accessibility also, the accessibility to the tooth that you treat, if you have a patient with a limited mouth opening, for example, so this will make it more difficult to do this type of access cavity. Presence of facilities and equipment available. This is a very important issue we discussed in the previous slides, that we should have a good source of magnification and illumination. We should have the right tools like the new types of burrs and flexible instruments. We should have a modern imaging technique like the CBCT in order to be sure that we have no missed canals or have no missed anatomies with this type of contracted access. So the message that I want to deliver from this part of conservative access cavity is that conservative access cavity could be prepared for certain cases or canals only. As we said, it can't be done for every case or every canal. You can do this type of access only in certain cases in order not to compromise the ability to locate all the canals and in order not to compromise the efficiency of subsequent root canal treatment procedures. This was the last slide in my presentation. I hope that this presentation is useful for you. Thank you so much. And if you have any questions or if you need to add anything or any point, you are most welcome. And I'm very thankful for your attention. If you have any questions, you are welcome. I want to thank you so much. Please stay safe, stay homes, and keep learning. Thank you so much and see you again soon.